anybody not done that?
I haven't done yet.
Who was that, Isaiah?
Yes,
You have not contacted them?
not yet. I was planning on doing it after the class.
Okay, you should have already. Okay? So you need to make sure you do that today, and you need to make sure that they are aware to contact me if they have any questions. Okay?
Professor Melia sent an email to my clinic, but I haven't received anything back.
I would ask that you call.
Okay.
Okay, if you haven't gotten a confirmation, I would ask that you call just to reinforce it.
Thank you.
Okay, if you haven't gotten a response back to a text or an email or whatever, just make sure your message gets through. We don't want them thinking you're just not showing up.
And if,
Professor Millie, is it just for this week so far?
As it stands right now, yes, it's just for this week.
Okay.
and if someone's having a hard time getting through and not getting any response from your clinical instructor, please let Professor Maley or Professor D'Onofrio know so they can make sure they follow up with a call and speak to the coordinator at the clinic. Because as Professor Maley said, we don't want people to think just to show up. All right, so there has to be some kind of a contact with someone. Okay.
And the other thing I just want to mention briefly, you know that I'm in the process of placing you for your summer clinicals, which is in process. Obviously, summer 1 is going to be placed before summer 2. But I just wanted to remind you that, as we talked about weeks ago, this is somewhat of a moving target where clinical sites may be changing their placement requirements, their clearance requirements, and some may mandate that you be vaccinated. Okay? We cannot mandate that you be vaccinated against COVID, but a clinical site absolutely can, and some are. I can tell you specifically, Mountainside is going to require it, and they will vaccinate you if you have not been vaccinated. All they need to know is that you're willing to be vaccinated. So what I am going to need to know from each of you, or any of you rather, I should say, if you object to being vaccinated, I need to know that via email. You need to email me. But please keep in mind, while you can refuse to be vaccinated, a site can refuse to admit you if you're not vaccinated. Just keep that in mind. And as things develop, again, things may change. Things probably will change. So will this be the case 2, 3, 4, 5 months from now? We have no idea. We have no idea. But please keep that in mind, because as far as I know, there's only 6 of you that have been vaccinated, and that may have changed, and you will need to update your Castle Branch information with that vaccine information if it's changed. I mean, that's going to be true with any of your Castle Branch information. If something has changed and been updated, you're going to need to get in touch with them, okay? And you need to update that updated vaccination information. Which brings me to my last point. One of the things you need to understand when you start your clinicals, which is, you know, the way you're evaluated is different than the way you're being evaluated on this observational assignment. And as you see, when you look at the CPI information that you've had to review, and so that you can do your own self-assessment, patient safety is number 1 always for every clinical site and for every clinical assignment. And protecting patients against a communicable disease is part of patient safety. So when we talk about patient safety, we're not just talking about guarding, hand placement, the use of a gait belt, which are all very important. Well, if we're putting the patient at risk for a disease, that's a patient safety issue too, and something that a clinical site is obviously going to be very acutely aware of right now. So please keep that in mind during your clinical assignments, and it's why they're going to be so insistent about proper precautions and perhaps requiring immunization. Okay? So we just wanted to emphasize that right now because of, you know, what we're all dealing with right now and what is still going on with the pandemic. You know, so please keep that in mind. That's one of your performance indicators, is maintaining patient safety. Okay?
And And we will be doing Zoom on Monday, and we should be returning back to school on Wednesday, in class, okay? So Monday there's Zoom pediatrics as well as the PT class. Any questions? Any concerns?
Any questions about any of that? About my information? I'll let you talk to Dr. Stutz-Doyle about your exams in the class.
Also, I just have a question for the whole class. Are you guys, because no one sends me daily monitoring reports. You're all monitoring your
Health check.
your health check. You're all doing that, right? But Professor Maley provided you with that early on this semester. Are you doing that? Are you guys still keeping records?
Yeah. Yes. Always in my circumstance.
You are.
Yeah, the calendar reminder that you received, that daily health check. That's important to maintain still. And it's obviously going to be important to maintain again as you move into your clinicals. Even more important.
Okay?
Okay?
Wait, so we're supposed to still be sending you that? Via
Absolutely.
email?
Absolutely.
Okay, I haven't done this.
That's why it's a daily health check. Not a once health check. It's a daily health check.
Right, well, I haven't been getting the I used to be getting reminders in the calendar, but not anymore, so.
You should have added it to your
Okay,
calendar when you got the initial reminder. It's got to be on your calendar. You got to accept that calendar invite. That's how it works.
I'm assuming Wednesday will be practical.
No. We were going
Chris, you don't need me now, right?
No.
Okay.
We had discussed that Wednesday will not be the practical. What we'll do.
Oh, I'm sorry. Okay.
No, we didn't discuss it yet, Chris. We had discussed it prior to everybody getting on. Wednesday will not be a practical because I think that some of you had requested to have additional lab time to prepare for the practical. So the fact that we can't meet for the additional lab time this week, we'll push the practical back. I don't like that idea, but we're doing that. It's doing that for you guys. Next week, however, don't forget that it is Good Friday, right? Next Friday? It's Good Friday, and there's no class anyway. That doesn't mean that you don't go to clinic. If clinic is still scheduled, you're still going to clinic. However, since the school will not be open that day, you cannot come in to do the practice that day. So you'll have to pick alternate days to do that. We'll have the practical the following Monday. However, this Monday, today we're going to go over some case studies in modalities just to make sure that you guys are good with choosing the right parameters and able to push the right buttons, etc., etc. On Monday, what we're going to do is I'll start a gait lecture, and I think maybe we'll show some videos of gait, and we'll talk about things. We'll talk about the different parameters associated with heel strike, foot flat, etc., the phases of gait. And then on Wednesday, we'll do some gait analysis, observational gait analysis, where you guys, we do have butcher paper at the school, so you won't have to bring in any butcher paper, but when we come in next Wednesday, you will have to bring in some kind of a tray, and in where you will step into a tray with powder to make a footprint, on butcher paper. So, Professor D'Onofrio, we have enough butcher paper, right?
You're muted, Professor D'Onofrio.
We have enough, we have enough butcher paper powder, but maybe if each each group, and you guys talk amongst yourselves, like the person you work with, just need a tin, like one of the metal tins that you bake with. Powder goes in there, you step in there, then you walk, and then you measure, the game parameters will tell you what to do. But it's just like a metal cooking tin that you throw out afterwards.
Yes.
Aluminum, that's what they call it.
A baking tray, guys, in case, is what I think he's trying to say. Yeah.
Okay, so that's how we'll start next Wednesday when we come back to campus. But today we'll put up some additional questions and in preparation for the practical exam. And we'll ask you questions the same way we will in the practical exam. So, Kevin or Professor Nafia, you have those questions. Let's break up into groups for about 10 minutes, 15 minutes. Let them look at the questions. Let's monitor them and discuss. And then we'll come back and we'll do them all.
Okay.
Professor Stutz, just a quick question. So tentatively, we're thinking April 5th for the practical?
Yes.
Okay. Thank you.
So Dr. Stutz, do you want to put us into breakout rooms so we go over these questions?
Yeah, hold on a second. Yes, I think that's what we'll do. We'll put everybody into. How many breakout rooms? How many people do we have? We have 4 of us, 5 of us.
Yeah, there's 5 of us, right?
Yeah, 4.
4 of us.
So 4 breakout rooms.
So we'll do 4 breakout rooms.
Well, Linda's here too, or is she?
Yeah, here.
All right. Can we do 5 breakout rooms or 4?
Yeah, let's do 5 breakout rooms. That could work.
All right. You know what? Let's do 4, and I'll jump in and out of them. So Linda, because I'll jump into Linda's too.
All right, sounds good.
All right. And I'll sign them automatically. Okay.
Hello?
Hey guys.
Hey guys.
Morning.
Did she email us these questions?
Yeah, I think these were emailed before. I don't know.
Okay, so like way back.
Yeah.
Back in the day.
Could someone just
Like
read me
last week or so.
Could someone read me the first question, please? I just want to. I have a weird
Oh,
setup
yeah,
going
do
on.
we not have...
Change your share onto the thing.
The 37-year-old secretary.
37-year-old secretary.
I mean, they didn't specify which one they want us to look at. It's just kind of like whatever we want. Or we can't go through all of them in 10 minutes.
Yeah, they didn't specify.
So is there anyone that none of us have like done yet? Or one that's looks challenging. Let's pick a challenging one.
Yeah.
Okay, got it.
Is it questions too, or is it modalities? Oh, it's modalities.
It's called, modality practice questions.
Okay.
You guys want to do number 16? Volleyball player?
Sure.
All right, let's go.
What do you guys think?
All right, so
where there was excessive inversion of the ankle, so we're looking at ATFL, sprain,
Inversion and also
reflection.
Plantar.
yeah.
Implant reflection.
So it looks like ATFL.
We can do HVPS.
Yeah, that's good.
Oh, high volt for the direct current, you mean?
Yeah, to control the edema.
I'll be honest, I don't know how to use the high volt on any of those machines.
Yeah.
There's a button where you can literally like press high volt, but we haven't really talked about it that much. But maybe like later on we'll do more about high volt.
So high volt on the, are you talking about on the smaller unit or one of the bigger ones?
The smaller ones. I'm not sure the bigger ones, but I know the smaller ones has that.
Yeah, the smaller one.
Yeah.
Guys, hot take. What if we use a microcurrent in ice to manage edema?
Yeah, I like that.
Microcurrent? What do you mean? What's that?
That's that sub-sensory threshold current. It's like the patient won't feel it, but it's used to manage edema clinically.
So on the machine, how do you get to that?
Dude, it literally just says micro on it.
Really?
Micro button.
They also do like a Russian and a white phasic. Was it 10 on, 10 off, like dorsiflexion, plantar flexion for this one?
That's for neuro-read.
Yeah, just because it says grade 3, I think you don't want to do like something that aggressive.
Yeah, I don't think we want to do it just yet. Especially, we're not going to want to get that ankle to be moving, especially, right away.
First.
Right, we want to control, we want to treat that edema, right? So some sort of elevation, an ice pack, and then, we'll choose what kind of stim.
So we could use direct current, we could use the microcurrent. I think IFC is also pretty good but I don't know if we would need 4 pads for this.
I mean, that'd be a lot.
I mean, I just don't know where you'd put them all. So then, let's say we're using either microcurrent or direct current, where would you guys want to put the pads?
I would say the calf, because you don't want it directly on the edema.
Well, so if Monica, you said before direct current.
No, we'll go with microcurrent, because HVPS is pretty aggressive since it's grade 3. So, yeah, let's go with microcurrent.
Okay, then where would you want to put the pads? And there's how many pads? There's 2 of them, right?
2, and I'd still say the calf, because I don't think in any circumstance we'll do it directly on the edema, unless I'm wrong.
We want to surround the edema, so just adjacent to. Like, you don't have to go over the ATFL, but we could go, like, by the like underneath the malleoli, or, probably, like, so basically you just want to surround it. I think the calf would be a little high.
Okay.
We probably want to do both malleoli, right? Like, just distal to, are we going distal or proximal to the malleoli?
To the malleoli would be right at ATFL.
Yeah, so.
If we're talking about the ankle, it's got to be all swollen at that point. So if we're on the malleoli, you're pretty much on the edema.
Yeah.
You can do non-thermal ultrasound. Just to like facilitate the inflammatory, so like we get some good blood going on and stuff, especially that's acute.
Yeah.
Well, it's already got a lot of.
I like that.
It's already got a lot of fluid in there, though. We don't need any more inflammation.
No, but like I think, and I think it's from the PowerPoint, like it helps promote like a good inflammatory like phase. If you like use the ultrasound to push away the bad blood and facilitate more of the good blood, but in a non-thermal sense.
What about an indirect ultrasound?
Yeah, you can do that too.
Put that foot in some water, hold it about half an inch away, just slowly work the area.
But are you thinking about like thermal sense? Because like a thing that might.
What, non-thermal? Like indirect. So.
Oh. Okay.
So yeah, you're putting your foot in a basin, because it's kind of hard to get that ultrasound in that area, So like a smaller head, maybe like a.
Was like 0.5 to 1 inches away from the foot.
Yeah. About
definitely on the exam.
Oh my God! Was it 2 centimeters? I pulled out my ruler.
Yeah, but the acid in centimeters. I noticed that. So
Yeah.
I had no idea.
Those guys, one thing to consider is, you don't want to have it necessarily in a dependent position if we don't have to have it there. We were talking about before having it elevated.
Yeah, because if we're treating it when it's down with that type of treatment, we probably want to, keep in mind that keeping the elevation of that ankle.
Yeah, did we talk about ice already?
Yeah, ice.
Okay, we did.
Of course.
Yeah, like 10 minutes on.
Right, so elevated ice, and then I personally like the microcurrent that Devin was suggesting, and having the pads on either side of the edema. So basically directly on it.
Okay.
But, there's more than one way to skin a cat.
Linda, you're in here, right?
Yeah, I just got here. What problem are we on?
16. We're the front line freshman.
The last one.
I'm sorry?
Number
16, we're on the last one.
16? Okay. Thank you. Let me catch up to you.
Where does it say microcurrent is good for edema? I'm trying to look that up.
That's just from my clinical experience, man. We've used that for multiple cases with edema clinically, where I work. So that's just kind of just pulling something out of the bag from my job.
Okay.
Although I don't know how to do it on the machine, the direct current that Monica suggested before, I think would be a great option. You had the treatment pad on the edema itself, and then the dispersive pad a little bit more proximal up the leg.
I forgot. We would do co-contraction or reciprocal for that.
Neither. You just put it on there and let it do its work.
Are you talking about the ankle pump for this one, or?
No. Just a direct current. Well, we could also have ice on there as you did it while it was elevated, but it wouldn't necessarily want to have, we talked about before, the action. You don't want to have too much action on something that's this acute. It just happened, right? So we kind of got to let the person rest a little.
Do you guys think we can do an ice massage with this thing, or no? Because I'm a little confused by ice massages.
Can everybody see my screen?
Yeah.
So you're doing number 3?
Number 16.
So number 16. Okay, and Devin suggested microcurrent. Yes, you can use microcurrent. We have done over microcurrent. The microcurrent is good for edema, but that's not being tested on the state board. This is why we did cover, we did say that microcurrent is used at a much different intensity. And it's
Sub-sensory threshold?
Right. However, let's talk about, somebody said they wanted to use DC current or direct current. Who said that they wanted to use direct current for this?
Me.
Would you use direct current? When do you use direct current?
Iontophoresis, denervated muscles.
And wound healing, that's it.
Right. Is it the denervated muscle?
No, it's not.
It's not a denervated. Is this an open wound?
No.
Okay. So why would you choose DC current?
Oh, I'm sorry. I meant to say biphasic revulsion, so we could do reciprocal 10 on, 10 off for the edema. That's what I meant. Yeah, that's what I meant.
Okay. All right. I just wanted to correct that.
Yeah, thank you.
Only because I wanted to make sure that we're all on the same page, okay? Because you don't want to use direct current on that. It's just obnoxious. And what's the difference between direct current? Didn't you guys have a question like that today?
Yeah.
What's the difference between a direct current and then alternating current?
I mean, direct current just, it's like unidirectional, and then alternate currents like bidirectional.
And what else does it have as far as pulse duration? How is it different from AC current?
I mean, DC current is either positive or negative, while AC current is negative and positive.
Okay, Joe, how does it differ in pulse duration? Is that Joe? No. That's Chris? Who's that? Who has the hat on? Joe?
I don't know.
All right, so my question was about pulse duration. Joe?
In regards to?
We're been?
I'm just sitting right here.
In regards to what we just talked about?
What?
No. Direct current.
Oh, in regards to direct current, the phase duration?
Yes.
Isn't it just a continuous wave, right?
I didn't ask you about the waveform. I asked you about the phase duration. The pulse duration. How is it different from AC? Is it different from AC? And if how is it different?
It's noxious.
It's different.
Noxious, noxious is the current itself. When we're talking about the pulse duration, what are we talking about?
The width.
Yeah, the pulse width. So how is a DC current different in terms of time, what time the current is on, to activate those fibers? Because we talked about the fact that this is used for what kind of a patient? Patient who has a denervated muscle, right? So
we're in milliseconds.
So we're in milliseconds as opposed to microseconds. That's the phase duration we're talking about, right?
Oh, that's what you were asking?
Yes. And wasn't there a question on the test about that today?
Yeah, so I don't know.
Professor, I definitely have gotten this confused repeatedly, and I'm not sure why. It's the high volt.
Yes.
I thought it's been talked about that we use the high volt with a negative polarity, like with edema.
With edema, yes. Mm-hmm.
And high volt is not direct current.
High volt is, they don't call it high volt direct current. Now they call it high volt pulse current. Some books still call it high volt pulse galvanic current. Galvanic current means direct current, but they're not actually being committal on a direct current because they're not letting it be on in a continuous form. So, this, you are right. But when we talk about this question, are you asking? Are you?
Well, before when we were talking about when you were asking Monica about the direct current,
right?
And I was thinking that might not be a bad option, but then, because I thought high volt pulse current with a negative polarity would be good for this situation, but if it, I don't know if that's the same as direct current, because then you said direct current would not be good for, edema. Right. That's kind of confusing.
Only because when she said direct current, what I was thinking about is a monophasic direct current. And a monophasic direct current is, that would be continuous, is not something that you would use. However, if we're going to use high volt, yes. And if Monica, if that's what you meant, if you did say high volt, because I came in late. So if you did say high volt, you are correct. Because you can use high volt with this. However, it's considered a high volt pulse current. It's not called a direct current. And I'm not saying that because it used to be called a high volt pulse galvanic, or no, it used to be called high volt, yes, pulse galvanic current, and they stopped using that terminology. I've looked in many books, and no one is calling it direct current. They're all calling it high volt pulse current. I just didn't want you guys to get confused. Can you use high volt with edema? Yes. Would I put a direct monophasic continuous current on this limb? No. That's all.
Gotcha.
So high volt pulse current, yes. And if Monica, if that's what you refer to, yes, you can use that. You can use that. The other thing that Monica suggested was a biphasic or some other current that had 10 on, 10 off. Absolutely. And then there was a question, would you use it reciprocal or would you use it alternating? So what do you think?
Reciprocal.
Reciprocal to pump the edema up into the body?
Yeah, so the ankle pump thing, right?
Yeah.
Okay, so who was that, Rich? Who was that? Rodney, who was that just said that?
Ankle pumps?
Yeah.
Yeah, it was me.
Rodney. So you said that to pump the fluid back up to the body?
Yeah.
Okay. So where would your pads be?
So two pads should be on the interior, and tibialis anterior for dorsiflexion, and for plantar flexion, it could be around like the gastrocnemius area.
Right. And Monica, if you were going to use this with high voltage, what would you be looking for?
The treating pad on the edema and the dispersive pad up and away.
Okay. Right. So that's what you could do. Good. So that's 16. That's easy.
Professor SD, I have a question. I mentioned this, and then I just want to ask about non-thermal ultrasound. Would you use that on this type of patient?
You can.
Or would you not?
You can. But that's a good point. And what we're pointing out, I think, through this, is that you could use more than one modality for one thing. To treat these things. What else could you use to treat the edema? Besides your high volt, besides your biphasic, besides your, what you just mentioned,
ultrasound.
What else could you do?
Compression.
What else could you do?
Ice, elevation.
Ice. So could you use a compression pump?
Yeah.
Yeah, definitely.
So what parameters would you choose if you used a compression pump? Linda, you could talk about that too.
Maybe, I want to say gradient from distal to proximal, making sure that it's not like a constant pressure throughout the whole boot. You want to pump the lower part first and then gradually work your way up.
So segmental.
Yeah. Intermittent.
Most of your compression pumps automatically do that for you. I think we're looking for more is what setting pressure are you looking for? Am I correct?
Yes. What setting would you use?
You certainly wouldn't want it to be you certainly have to have it lower than the diastolic, so that's a start.
Thank you. But what else?
You probably want to get it as high as you can while keeping it under the diastolic.
You got some numbers in the lecture.
So maybe 40 to 60 millimeters of mercury.
Was that in the lecture?
40 to 80, I'm sorry. 40 to 80.
Right, Lynn?
Yep.
All right.
What is it for the arm, even though that isn't the problem? What is the numbers for the arm?
30 to 60.
Thank you.
Now, the other thing, as I said, I walked in a little later. Linda, did you ask any other questions about this question? Because it says, what's the mechanism of injury? Did you guys determine that?
Yeah, plantar flexion inversion.
Plantar flexion and inversion. Mechanism of injury. What's the most common ligament involved?
ATFL.
What's that stand for?
Anterior fibular ligament.
And how would you wrap this leg in order to prevent the injury from reoccurring?
Distal foot and dorsiflexion.
How would you wrap this leg in order for it to prevent from reoccurring?
Keep the foot in dorsiflexion.
Just dorsiflexion?
And a little bit.
And eversion.
Eversion. What muscles would you work on as far as strengthening? Joe.
I guess the anterior tib and peroneal.
The anterior tib and what?
Peroneals.
What peroneals?
The important ones.
The important ones. Okay. So this is your practical exam. These are your practical exam questions.
Oh, I'll be fine.
So Joe, no, I want to know now. The important one. I like that. The important one.
Partial credit.
You get partial credit for that.
I'll take that.
Chris
Yeah.
Firstwood?
They're on the left side of your leg. they do eversion and dorsiflexion.
Fibularis longus and brevis.
Yeah. What's another name for them?
I'm sticking with that.
Wait, what did you call them, Devin?
Fibularis.
Name for them.
Fibularis.
And brevis.
Longus and brevis.
What's another, which one?
The fibularis longus and brevis.
No. I asked, what's another name for them?
I gave you those.
No. I want to know. What's another
Herpes
name?
longus.
Oh, yes. Herpes longus brevis.
Herpes.
Yes, because you don't know which one you're going to see on the state board. You have to know both.
And then what, does the tertius do the same thing, or does that have a separate action? I'm trying to remember.
What does the tertius do?
I'm not sure if it has the same actions as the longus and the brevis.
It's a dorsiflexor and an everter.
Okay. So, it does, okay.
Dorsiflexor and an everter, yes. Where does that insert?
The tertius?
Yeah. Joe, why are you laughing? Are you?
Because I totally forgot the tertian.
That exists.
At least you're honest. Where's it insert? Where's it insert?
Lateral, tarsal. The fifth. Yeah.
Come on, you all have your magic boxes. You can just look it up.
No cheating.
Devin, you're already cheating. I know you are. Where is it?
The muscle arises from the lower third of the anterior surface of the fibula and the lower part of the interosseous membrane between the tib and the fib.
Where's it insert?
An intermuscular septum between the peroneus brevis muscle.
So it inserts on the dorsal surface
of the fifth metatarsal.
Yes. Okay. All right, let's go to number 15. Take it, Joe.
Well, I gotta go on to my other screen.
And it's not cheating, it's resourcefulness.
Why are you going to your other screen? Go to, it's up here.
Because I had my other screen up, and it was covering half the screen. Hold on. 15. 43-year-old female awoke 10 days ago with right-sided facial paralysis with inability to fully close her lips and eye on the right side following the recent sinus infection. Oof. Examination shows only trace contraction to the right side face muscles.
Ooh,
So we're looking at Bell's palsy most likely, right?
You want,
Okay, if we are looking at Bell's palsy, what is Bell's palsy?
paralysis of the facial muscle on one side. It's transient, so it doesn't last.
Cranial nerve 7. Is that
So
what we're
what
looking
nerve? Cranial nerve 7. What's cranial nerve 7?
for? Facial nerve.
Okay. So she can't close her eyes, or she can't fully close her lips and her eye. So what muscles are we talking about?
Trochlear? Oh no, abducens.
No. Which ones? Which ones are we talking about?
We
Which
didn't cover
muscles
facial muscle.
Which muscles are we talking about?
It's ocular. Ocularis.
Orbicularis,
Ori.
oris, orbicularis, oculi, right? We're talking about those muscles. We're talking about the muscles on the side of the face. We said facial nerve. If there are some people still believe, I think, Devin, it was your clinic, in using a type of stimulation for this, then the jury's still out because evidence-based practice shows it might be detrimental. But what are some people still using for this kind of type of?
We used a Russian stimulation, but like low
Use
duration.
Russian?
I mean, I guess so. I really don't know. It was like right when I started there, so I do not
Isn't
know.
that a DC current?
Yeah. That's what my clinic uses.
Rich, that was
like
you?
this.
That Rich?
Yeah.
Yeah, so what did we using in class that you could possibly use?
Well, we use like a DC current that was like what are the spurs of bed where you like kind of click and it turns it on for a second.
Right, so that was a motor point stimulant, right?
Yeah.
Yeah. And what did the clicking do? What is that button known as that you push and it alters the flow of current? What is that called?
Rheostat.
Rheostat, okay. Good. So you could do this around how many times to each motor point before you move on? 17, 125. How many times are you going to stimulate that muscle?
3 to 5.
Yeah, there's no more than 5, like 3 to 4, 3 to 5. Some people do 5, but no more than that. Why? Because DC current is noxious. DC current also causes burns, right? Mm-hmm. Okay, so we don't want that. What else could we do with this patient?
I was gonna say ice, quick ice.
Yeah, quick icing, right? And he asked the patient to look in the mirror for some feedback. When we talk about feedback, but that was the question in the test, right?
Yeah.
What did you guys write for that answer? If you want feedback, what does the person have to do?
Coordinators.
So there was a question about if a patient has median nerve injury and they wanted feedback.
Contraction. You're looking for that contraction of muscle.
The answer was to place EMG, right? Surface EMGs over the what muscle?
Pronators.
Pronator, because the pronator is innervated by the median nerve. Good. Okay, so that's what we do. Rodneil, can you take number 14?
A 38-year-old postural carrier is treated for chronic mechanical low back pain aggravated by prolonged walking while carrying his mail bag. He has decreased endurance of the lumbar paraspinals.
What do you want to treat?
His low back.
What specifically?
His lumbar paraspinals.
Yep. What do you want to do?
IFC.
Why?
To just treat the pain.
What do we know about IFC as opposed to any other modality?
IFC feels a lot better.
And it goes deep.
It's pretty strong.
IFC goes deeper. Okay, so it penetrates deeper. It feels a lot better. You mean it's more comfortable, right?
Yeah.
Why is it more comfortable?
Because of the high frequency.
Okay, so what about the high frequency?
The frequency,
These are the kind of questions we're going to ask you next week.
Well, higher frequency, it's going to have a higher depth of penetration, but it's not going to be able to.
It's not going to they're not going to feel it really.
Of course we're going to feel it. Of course you're going to feel the stimulation. Why does it feel more comfortable?
Is this stimulating the A betas?
What is the frequency, the 4,000 hertz, 4,100 hertz on this machine? What does that do to skin? Or does it have does it have an effect on the skin at all? Devin?
It's less. There's less tissue impedance because of that 4,000 hertz frequency. So it's going to penetrate deeper through the tissue without tissue impedance.
That's correct.
Thanks for coming.
You wait for your practical.
Yeah, Devin, you better be careful, man.
What, Chris?
I said you better be careful.
One more time.
All right. So
All right, he's ready. Okay, I like that. Confident.
So you would have to take these electrodes, and how would you place them? I want you to be as specific as you can, all right? The more specific you can be, the better off and the easier you get through your practical.
Diagonally on the spinal, diagonally from the spinal cord.
Diagonally, you put the spine. Okay, good. Can you do a target? Can you sweep this? Can you scan it? And when would you do that and why?
You would scan and sweep it just to prevent accommodation.
So prevent nerve accommodation, adaptability of the patient. What do those parameters do?
So scan is for amplitude, and sweep is
What
for.
does it do to amplitude? What does it do to amplitude?
It just changes, like goes up and then goes back down, then does it again.
What's that known as?
Modulated modulation.
Modulation. Good. Okay. Can we use any other modality with this patient?
Ice, heat.
Ice, heat. Anything else?
1 megahertz ultrasound.
Okay, if you want to use, does ultrasound work on muscle?
No, it's more ligaments and tendons and joints and stuff. So maybe not.
Okay. Can you do any traction?
Ooh.
Yeah.
Yeah.
What kind?
Lumbar
traction.
At 25%.
So give me the whole thing. Intermittent, constant, what parameters, how many pounds?
What I think it'd be intermittent. And I think for his low back, it could be like either 50% or 25%.
Well, 25% for the muscle.
25 for the elongation of the muscles.
Okay, so 25% then. Okay.
So you would do 25%. Okay, so you got to be that specific, okay? You want 25%. You want to use heat, you want to use hot, cold, you could use those. Let me see who else. Devin.
Yes.
You have a portable TENS unit that you were instructed to provide this patient for home use. What instructions are you going to provide the patient for the use of the portable TENS unit?
For TENS units, oh man, there you got me there.
Give it a whirl.
Huh?
Give it a
whirl.
Give it a whirl. Thanks, Chris. Appreciate your input, bud. We would use for the portable TENS unit, we want to stimulate sensory fibers and release those endogenous opiates to like block pain signals. We're going to use that gate control theory to go from there, obviously. Probably benefit from a well-structured therapeutic exercise program as well.
So I answered that modality. And do the rest of you agree with that?
I would say.
What's up?
Do you agree with that?
I think I agree.
Well, I think you're wrong. Chris, do you agree with that?
Boy, you're going to be in that little higher frequency, lower phase duration, about 20 minutes treat time with that.
I think you're wrong.
So
good about it.
Chris?
Well, I think you mentioned that it was if it's this patient, it's a chronic issue. So we probably want to go more low frequency, higher duration.
All right. What are you going to say? What's the rate?
The rate? 0 to 10, so maybe 2 to 10.
What's the duration?
Swoop. And then the duration, because it's a larger muscle, you could have it as high as maybe 300 microseconds.
Can you sweep a portable TENS unit?
I haven't been able to use it in lab. I'm not sure if you can, because I got my hands on it the one time. If you could, I would, but I'm not sure if you can.
Well, you can't sweep it.
You can't? Okay.
You can't. But you could burst it. And you can, there are some of them that have modulation. Yeah. And if there is a possibility to modulate, absolutely modulate the current. Can't wear, all right, that's good. Ice, heat, anything else? Can you use biphasic stim?
Yeah.
Can you use cycle?
He has decreased endurance of the lumbar paraspinals.
Guys, can you use cycle for pain? What did I say? Positive for pain, negative for can you use high volt for pain? Yes.
Yes.
Wait, would this be considered high volt pulse duration, or would it just not pulse duration, pulse current?
High volt pulse current, yes.
But not high volt direct current, which is continuous.
Correct.
Okay.
Correct. So, and we don't even have those machines. So the only thing they make anymore is the high volt pulse current. So can you use high volt pulse current? Absolutely, you can. You can use a high volt pulse current and use a positive polarity. What kind of a response do we want from the patient? What do we say to the patient? Tell me when you feel it?
like tingling, something like that.
Tell me when you feel tingling. What do we say, Devin, now that you know what you're supposed to do?
Should be strong. Should be strong but comfortable.
Be strong but comfortable. Absolutely. Linda, you have any other comments?
Not that. Question. I might be foolish here. What about combo?
You can use combo, sure. Problem with the low back, guys. What's the problem with the low back and combo?
Very large surface areas. You're going to need it.
It's a real large surface area, so it's going to take a long time, depending on where it is. If it's like one little area, absolutely, right? Right. All right, 13. Rodney, take 13. Or Monica, take 13. Or Rodney, take 13.
Okay. Patient is 17 years old, lacrosse player. Patient is 17-year-old lacrosse player who sprained her ankle in a march yesterday afternoon. She presented to the She presented to the clinic the next morning with acute swelling of the left lateral ankle and laxity in ligaments of the lateral ankle. Range of motion is decreased secondary to discomfort and swelling.
So we have pain and edema. So if we have pain and edema and we want to use some kind of a modality for pain and edema, because we talked about this, similar to the last question, but if we want to work with pain and edema, and let's say you wanted to use, what would you use for pain and edema?
Combo?
Combo? No.
No? Okay.
I don't think I'd use combination. No. Combination is going to be it's going to hurt. Of course, the electric part of the stimulation, it's going to be, I think it'd be a little bit too noxious for her.
I mean, you could always just throw ice on there.
Do like a pre-mod and ice while elevated.
You could do a pre-mod, yeah, pain and edema. If you wanted to do, if it was a larger area and the calf was involved too, you could probably do something like an interferential and pick the high-low setting, but the high-low setting would work on an acute and a chronic problem. Well, I'm sorry, she doesn't have a chronic problem. Sorry, I misread it. She just got an acute. So an acute pain or acute edema are the same parameters. What are we talking about as far as frequency? Almost spend much time on this question. It's very similar to the last one. But what are we talking about as far as frequency? And
high frequency.
High
low duration.
Low duration. Excellent. Okay. Let's go to number 12. MVA 2 days ago, soft tissue, posterior cervical spine, upper thoracic region. What do you think is going on?
Posterior cervical.
Arthritis.
What would you say? What? Arthritis when MVA 2 days ago?
Oh no, sorry. I was thinking about spondylolisthesis or something and all that stuff.
So what do we think? Tell me, 2 days ago she had an MVA. What are you going to answer?
Well, where the pain is, you're going to ask them, exactly where it is and what motions cause you more pain.
You think it's important to know where she was hit from?
Yeah, what direction? My mind's jumping to like acute muscle guarding as well.
Okay. All right. I agree. You agree, Linda? Linda, you still with us?
I'm with you. I'm sorry, I missed the question.
Okay, that's all right. I'm just asking if you agree. 2 days ago, so 2 days ago, like 48 hours, right?
Right.
So she went to soft posterior cervical spine, upper thoracic region on the neck. What do we think about that 2 days ago? We still think it's kind of acute?
It's, I think it's still acute.
Yeah, it's inflamed.
Right. So if we're thinking she's got pain in the posterior cervical spine or the upper thoracic region, what else are we going to ask her? She was hit from behind.
I'm also worried about a concussion here.
Did she hit her
I know
head?
that has nothing really to do with what we're doing, but
Or a whiplash injury.
Okay, she had whiplash injury. What else will we consider?
Some sort of like neural injury as well. So that like
Okay.
maybe like an HFP.
So, well, you want to know if she got any ridiculous symptoms, right? Those are the questions. Yes. What about face pain? What about headaches? Do you want to know anything about that?
Yeah.
Okay. What happens when you get hit from behind?
It comes forward.
Extension, remember this?
Yeah, you get extension and flexion.
Right. So a moving object stays moving unless some kind of reaction, unless something makes it stop. In that event, it's going to go in back and forth, so flexion and extension. What's going to happen is the jaw probably open and close, right? So anything going on with the face, you're going to think about that. Palpation right up a trap. So maybe she had her arm up like this and it tensed. We don't really know. Not giving us enough information. That's stuff we would ask her. So for that tenderness in the right upper trap or that posterior cervical spine, and that active range of motion is painful and limited, what are you going to do? What do you think's going on?
Ice.
Ice? Okay. Anything else? You're going to put her on traction at 40 pounds, right?
No,
That's too early. That's too early, right? To do traction.
it's too early and it's too much in general. Too much weight. I would do pre-mod under the ice. So it's acute, so high frequency, low duration. Ice on for 10 minutes or so. I would do something like that. I don't know.
Would you do, I guess, like IFC for this one? Or would that not be targeting the area?
You did IFC?
Yeah, for this one.
IFC will help with the pain, right? So you
Not the demo. Or not demo, the limitations.
You can. It's not going to help with what is causing the limitation in motion.
The right trap is probably spasming slightly.
Okay.
So
It could be spasm, it could be swelling, could be some bleeding in the muscle itself, right? All those things can cause a limitation in motion. So, because this is only a modality exam, that's what we're talking about. What modalities could you use to help with the patient? Okay.
But even if it was spasming, you still wouldn't want to use, you still wouldn't want to try to fatigue the muscle. We would want to wait on that. You could deal with the spasm later, maybe wait a week for that, because if they just had this injury, well, we just basically want to get the inflammation and pain under control. So like they were suggesting pre-mod or IFC for starters, and then later on you could work on the spasm if that were the case.
Correct. Could you use a pulse ultrasound?
Pulse ultrasound?
Like non-thermal?
Definitely non-thermal.
Well, no, because
that's more
musculature. Yeah.
Yeah, I'm not supposed to do that. All right, good. Patient is 43-year-old, status post CVA, left foot drop, sheet with modality. What do you think, Brian?
Left foot drop. We want to get them to dorsiflex, so I would do. And how old are they? 40.
43.
43? Oh, they could take it. Maybe give them Russian. On the anterior tib and on the gastroc, a good distance apart. And we want that pumping action for. Well, no. Okay, I take that back. Just on the anterior tibialis, and we want to do like 10 on. We want to do 50 off, ramp time 3 seconds, and just have them when it pulses on for the 10 seconds, have them dorsiflex as hard as they can to go with the machine to get that.
Okay, it's been a week and you're getting some return. You're going to still keep the parameters, contract, relax, 10-50?
So if they get better, let's drop it to 10-30 and then keep it going.
And then a week later, you're going to do 10-10, right?
No, because that's gonna just fatigue them, and then he's gonna walk out angry. So like.
All right. Now, what else are you going to provide for this patient? Who would you refer this patient to? To whom would you refer this patient?
So hold on, let me just sustain motor vehicle.
No, number 11.
neurologist.
Okay.
For function.
For function.
Yeah.
CVA.
Left foot drop.
Yeah.
I would refer to you.
Maybe a podiatrist.
Podiatrist? What's podiatrist going to do? Cut his nails?
I don't know.
Treat with modality. Yeah, maybe
That's
a
a doctor.
neurologist. If it's a real nerve problem.
Who? What did you say, Brian?
Yeah, like someone who deals with nerves, like a neurologist.
All right, neurologist. He's already seen a neurologist because he's CBA. What else?
Can I jump in?
Yeah, no, Linda. They have
Rats.
they have to say, this is what we're talking about. That left foot drop.
Someone
Well,
who.
what about some? Oh, sorry. Go ahead, Brian.
No, an orthopedist?
Orthopedist? The doctor's going to say, oh, you're doing a great job. Keep going to therapy.
Well, what about someone who could fit them for an orthotic?
Okay, and what's that person know then?
Don't know.
Yes, you do.
Prosthesis, some sort of I don't know.
Say it, no.
Prostate, like a prosthetic fella, or
Yeah, I second that.
Headache salad. Yeah, prosthetist or an orthopedist. Yeah.
Is that what they're called? Prosthetist?
my buddy is actually one of those.
Oh, nice.
Yeah, prosthetic salad. Yeah. That's what you're going to say. Anything, Linda? Was that what you were going to say?
I was going to say that also we could look into some gait training with wrapping the foot in dorsiflexion. So
What
that
about an FES?
No,
What
that
about
was.
using an FES?
Wait a minute. That was my next question. Hold on. Linda's going. Can we do something before that person gets their orthotic?
orthotic. Yeah, you could work on doing gait training with the wrapping, taking him into dorsiflexion, maybe a bit of eversion to keep it going with the proper assistive device, just to get him into the habit of not dragging the foot or hyper knee bending. Sorry, I'm losing my terminology as I talk.
That's all right. That's all right. So let me ask you guys another question. What's going to happen with this foot, or what type of gait? We've talked about it. We really haven't talked about gait per se, but we have mentioned this before. What do you think you're going to see?
So that steppage gait,
Stepping.
so the foot just kind of hits. You can't move into dorsiflexion, so you get that flop of the foot on
Right.
the ground.
You have an increase of knee and hip flexion. Yes.
You might also see a little circumlocation, swinging.
Well, they don't know that yet. But
Circumducting from the hip.
Yeah, you could see circumduction, you could do hip hiking, you could see lateral flexion of the trunk. There's a lot of different things that you can
And that's to clear the foot through gait.
Yes,
Correct.
yes. But we'll talk about that starting Monday, and then we'll talk about gait. All right, nice. Number 10, 22-year-old male ACL after reconstruction patient has extensor lag. They also have instability.
Oh, let's
Okay.
go.
Co-contraction. You want a co-contractor?
Yeah, let's do some Russian here.
No,
Yeah, we're
yeah.
gonna go Russian, VMO, Rec Fem, 10 on 30.
10 on 50 to start,
Okay, you're-
10, 30.
Hold on. You are not out in the field yet, so you could do you could say all the crazy things and say, in the real world, this is what we do. You are a student. You are taking a state board exam. I would like to hear what the muscle is.
The vastus medialis obturator and the rectus femoris.
Okay. What's the difference between the rectus femoris and the VMO and the vastus lateralis?
Rectus femoris is the joint muscle, crosses over the hip and the knee, as opposed to the VMO and the vastus lateralis, which are just knee extensors.
Okay,
They
so which
don't
one's
attach to the hip primarily, or at all.
the two-joint muscle?
The rectus femoris,
Rectus femoris.
And what are they innervated by?
the femoral nerve,
Femoral.
And where does the femoral nerve come from?
the lumbosacral plexus.
Lumbar.
Where? What level?
I'll tell you. I don't remember.
It's L2, L3, L4.
L2, L3.
Chris is right. L2, 3, 4.
L3,
What division?
That's a great question.
Wow.
What's the question?
What division?
What division? The posterior? No.
That was a good guess. It's correct. It's correct. Posterior.
Nice, Joe. Let's go, buddy.
Okay. All right. So you said you'd use Russian stem right to the vastus to the rectus femoris and VMO, right?
Yep.
Okay. The VMO for the extensor leg, so to speak. What's the VMO work doing? What? I mean, they all work during extension, but
the VMO is specific to the last 30 degrees of knee extension.
okay. What would you do for stabilization and put this patient in a functional activity while you're doing it?
Take it away, Deb.
Oh man, let's go. So we're gonna do. I mean, initially we could do like an assisted quad set with the Russian stimulation. So like the parameters would be 10 seconds on, 30 seconds off to avoid fatigue and allow for full muscle contraction, right? Or full muscle repolarization after contraction.
Okay.
And then
for stabilization.
Mm-hmm.
Okay. I mean, I would give you a therapeutic.
What's an assisted quad set or a quad set that's in weight bearing? Is that what you're saying?
Well, yeah, the quad set and weight bearing would be more of that terminal knee extension.
Just have them stand on one leg.
How?
You would have them either with a resistance band, and you could use a biofeedback machine on the VMO and the rec fem resistance band behind the knee. Have them move into that end range extension. You want to have that auditory feedback from the biofeedback machine, which would be that beep, right? And
but how can you do a static quad extension in standing?
TKEs, terminal knee extension. You just have them stand there, and then slight bend in the knee, and then extend.
You can do like a ball against the wall, like a small ball against the wall.
Yeah.
Yeah, for the isometry.
Feedback, so you get the quad set into a more functional activity. What if we want to incorporate in this person? What do we want to specifically look at? Just the quads?
No, you want to look at everything comprehensively. You don't want to just treat the quads. You want to move into the hamstrings and the lower leg as well.
Okay, so are the hamstrings really important to look at within an ACL?
Yes.
So can you think of a functional activity where you're going to place the stem on which incorporates both?
I mean, I guess you could do co-contract Russian on hamstrings and quads, but
while they do what?
Like a bridge.
Walk.
A bridge.
Maybe a lunge.
Maybe a lunge.
Or a split squat, or even some sort of hip hinge dominant exercise.
Yeah, RDL, something like that.
So I like those, and you would place. So you'd have to have 4 electrodes, right?
Mm-hmm.
And would we have them on co-contraction?
Co-contraction or alternating?
Reciprocal, right?
The stabilization, do we need co-contraction?
Yes.
We need stabilization. You need co-contraction for stabilization because you have an antagonist and agonist muscle group.
What frequency and what pulse width are we talking about?
This is
35 to 50.
Yeah, 35 to 50 for the frequency because you're going to get tetany without fatigue. And what's the pulse duration? I don't remember.
350 because it's a larger
muscle. Lower extremity, so it's 250 to 350.
Okay. All right. Good. 23-year-old paraplegic patient, large infected pressure ulcer. Okay, Monica, you're on.
Oh, paraplegic, I would say we're dealing with denervated muscles.
Okay.
So we could do HVPS.
For infected pressure ulcer.
Ooh, yeah, we could do wound control.
Okay, so you said HVPS.
Mm-hmm.
What are you going to do?
So for the wound, the gauze with saline, and we'll do non-continuous. On the wound, we'll do the dispersive pad.
We'll place the dispersive pad on the wound?
No, the other one, the active electrode.
Okay, so what's the polarity of that?
So
negative.
On a wound?
What do you say, Monica? What's the polarity?
I'll say negative.
Okay, why do you say negative? What's the big word here that's telling you should?
It's infected. It's infected.
Okay. Infected, and inflamed. Use negative. Okay. non-inflamed, non-infected, we use positive. Do we switch back to polarities if we're not getting the result we need? Yes. You can start, you can go back, you can go to a positive polarity, see if it makes any difference, but if a wound is infected or inflamed, initially we're going to use a negative polarity.
Okay.
Good. Number 8, patient 83-year-old female, chronic inflammation in both hands. What are you going to do? Right, Neil?
So there's we can do like paraffin.
Yeah. So tell me how you can do paraffin.
We can do the glove method. So before they use it, you ask them to wash your hands and take off any bracelets or rings. And after they do that, you could ask them to dip their hands, not touching the surface, but just touching the wax itself. It's
How many times you dip in it?
6 to 8 times, or wait, no, I'm sorry, it's 8 to 10 times.
Hey, Joe. Excuse yourself.
Sorry. They just come out.
Sound like my mom. All right, 8 to 10, right? Good. And what do we do after we take somebody out of the paraffin? What do we? Can they go into paraffin with a cut?
No.
Can they go into paraffin with their ring?
No, take the jewelry off.
No.
Can they go into paraffin with long fingernails that are fake?
They shouldn't.
What do you do before they even put their hand in the paraffin?
Clean them. Gotta have them wash their hands.
All right, since when are you Rod Neal?
Oh, sorry.
All right, and then as soon as you take the hand out, what do you do?
Me? Okay, so you just wrap it.
You just wrap it with what?
What's it called again? Like plastic, saran wrap.
Saran wrap and then what?
And then you wrap it around, and then you could also put like a hot pack or silicone hot pack around it too, just to keep the heat, and you leave it on for 20 minutes.
Okay. All right. Wait a minute. I lost the other.
Do you talk about compression with this at all?
You can.
Yeah, there are the simple gloves, the very lightweight compression gloves that, from what I've been told by patients, it does give some relief to the pain, especially with the chronic. If you're going to use those gloves, you do them with the fingertips off. They make them that way so that they have good feeling and can wear it through the day. They're usually over the counter.
What are they called?
Compression gloves.
Just compression gloves? Okay.
Tommy Copper puts it out. Not that I'm giving him a plug. I haven't used them. Also seen some wood gloves that have this, and they also sometimes come with grippies built in. So it's like a weight glove with a little bit of compression, but you can use your hand functionally through the day with it. The thing is, you want to give them more relief because the more they use it without overuse, the more function you get back.
Right.
There's also one other. What am I trying to do here? Did I close the questions? Oh, shoot. I closed the questions.
They're still up.
They're still up? You still see? All right.
Mm-hmm.
So you guys look at the other questions. I just want to see if anybody's in the room. Anybody got out of the breakout rooms. So go ahead, Linda, take it.
What am I taking? The 40-year-old female with bilateral ocrinon bursitis?
Yes.
Okay, gang, what are we doing with that one?
You're going to use electric stim, right?
I wouldn't.
No, you would never. So what are you going to do?
Ultrasound.
Yeah.
Ice.
Well, it depends on, it doesn't specify if it's more acute or if they've had it for a while. I guess we can assume it's chronic. It says bursitis.
Bursitis is inflamed, so you would use you wouldn't use heated ultrasound. You would use non-thermal on bursitis, right?
Right.
And it's deep. Well, I mean, not deep, but you want to get to the bone. So I would do one.
Area with a lot of muscle tissue?
No.
So your ultrasound is still good there. Non-thermal is good. What else do you want to do?
3 megahertz.
You can optimize and you also probably, as he was pointing out, bursitis means you have some edema type problem here, or fluid problem buildup. Oh yeah, you could do that. What else could you do?
Well, you could also do iontophoresis and get some dexamethasone in there because it's an anti-inflammatory that works on tendonitis and bursitis.
Okay.
Dexamethasone has a negative charge, so you could do, you'd have to use a negative charge on your treatment pad. So you could use that, ice, the ultrasound. Those are good options.
So far, what about after? Maybe some wrapping? A little bit of pressure?
Even if they don't have a lot of edema, you could still, that's something that you want.
It's a bursitis. It's not going to show up as a standard edema, correct?
No, it's just going to be within the capsule or within
exactly.
Within
so
the
I'm not going to get crazy with it, but I know some of the things they do use is a localized pressure relief too.
Which
I'm trying to get us back together, and I can't. I want to.
Stuck with us.
Huh?
You're just stuck with us.
I want to go back. I can't even get out. I don't know.
It might be Kevin who has to do it.
I don't know. I'm just trying to get us back to the main room. Oh my goodness. Stop share. Let's see. All right.
You are.
Let me close over. Well, let me join this one. Hold on. Oh, I'm in. Okay.
Bye.
Maybe, do we all have to leave the room individually?
Yeah, I guess.
Hey.
Leave breakout room?
Give it a shot.
Okay. Okay.
All right. Oh, there you go.
Whoa.
Hey, Dave, what were you saying?
Oh.
Dave, what were you saying?
That's still one of the all-time best hype-up songs is Thunderstruck.
Oh,
Yes.
Professor Doyle, what happened was right towards the end of we did all 16, by the way. Towards the end of our discussion, Victoria called, and she's calling crying because she's nervous because she has to be like the lead defenseman for her lacrosse game today. She has to shadow their number one player, so she's afraid of messing up. So I actually had her on our group, and they were giving her some advice on certain, psych out songs for her.
Understood.
All right. I think we didn't get through all of them because it was me, of course.
Yeah, we got grilled.
But I was trying to make sure that, and I'm sure you guys did it too, that we provided them with questions, I know, that we would ask in the practical exam. For example, if somebody had an ankle problem like that last one, what structures would be involved? What would you do with that patient? Where are those muscles? How would you take to prevent it from happening again? If you were to refer that patient out, to whom would you refer that patient? In the interim, what could you do? What kind of problems would you see while the patient was walking? All this kind of stuff we had asked in that session, because that's the kind of stuff we're going to ask, because we're trying to get you ready for clinic. So we're not just going to say, here, put this modality on. Stop looking at your watch, Dave. Put this modality on, and just tell me the frequency and the pulse duration. All right. So we're going to ask a whole lot of other questions, and expect you to have the answers. All right. I even asked in my group where the Coronius brevis was, or the fibularis brevis, as Devin wants to dish or whatever he said. And of course, he had to look it up. It is an illuminated box because he couldn't remember. So
I got hit in the head a lot.
anything is fair game. Okay, and plus you've got a longer time now to try to learn this stuff and to be ready for this practical. And we expect you to know the answers. So also give them to us like this so we don't have to ask you a question. Say I'm going to use interferential at a low frequency of 0 to 10 with a pulse duration of 250 to 350 because I'm doing a large muscle. And I'm looking for interferential stim because it's much more comfortable because it decreases the skin resistance. Blah, blah, blah. Devin, stop communicating with Dave. Dave. All right. So those are the, you can talk about me all you want and say anything you want to say about me. You will say anything someday. Someday. Okay. So that's about where we are.
Wow.
What a call.
Nail, meet hammer.
That's where we are right now. And Kevin is available. So those of you who need Kevin, please reach out to him. And any questions, any comments, any concerns? Yes, Joe.
When do we get our exams back?
You're gonna get your exams back probably by the end of today.
Beautiful.
Okay, what did everybody think of the exam?
It was hard.
Yeah, a little tough, but
I thought it was alright.
That is okay.
You thought it was hard? Was there anything on it you didn't know?
Converting centimeters into inches.
I think the better question to ask them is there anything on it that you may not have discussed at some point that they probably didn't remember?
The only thing that messed me up a little bit was the viscosity, but that's just because I didn't drill it.
Yeah.
Yeah, but viscosity is a normal word in the dictionary, right? It doesn't even you didn't even have to sit in my class to know what viscosity is. It's resistance, right? It's the thickness of a fluid is resistance. What happens when you have resistance? Is it easy to move when the fluid is thicker?
Ooh, I have a question. Is the labrum deep or superficial?
Deep.
Interesting.
What a question, Steve.
I know, Steve. This question is it has a little history because Steve was trying to give me his explanation for the extra credit, and I was just kind of like, I don't know, man. So he's still trying to hedge his bets right now.
Joint capsule's pretty deep.
Yeah, I told him.
I hope so. So, does anyone, Jay, Cindy, how did you guys feel? Monica? Ryan, how'd you guys
I felt pretty good. No one asked me, but I feel good.
Jay, anybody?
I felt okay.
I thought it was okay.
Okay. All right. So you'll get it back today, as Kevin said, and if there's any questions, then reach out to us. But in the meantime, you can get ready for the practical exam. So review all this stuff again. And also, I think that you should start reading gait. There's several books in which there are chapters on gait. One of which is your one that you used last semester, the kinesiology book that has a chapter on gait. You probably should start there. Sullivan is hard, but that's a great book. Eventually, you need to get to that point. But right now, if you start with the kinesiology book, it'll get you into the basics so that it'll prepare you for the harder stuff. Okay? So O'Sullivan and Schmidt, Lippert. There's also gait in patient care book, so it's in several of your books. So, and it's from easier to harder. So, and I'll send you a PowerPoint. Just start reading some of the chapters. Get yourself familiar with its terminology because there's two different types of terminology. There's traditional and the Rancho Flosso Amigos terminology. So you'll have to know both different types of terminology, because heel strike is not the same as initial it is the same as initial contact. So